Good afternoon, Adrian.
Yes. Hey, hi.
Adrian and Chee Tang. Hi, hi. Is Paul on here?
Hey, Paul.
Prof. Co and I are started sharing these sessions, and I've just introduced a very large panel looking at you. So maybe I won't go through that all again. So because it's your show, perhaps you can show us what you're going to have in store for us.
Okay. Yeah. So we have our team here. You want to introduce them? Yeah. So welcome to Heart Center again. Chee Tang here. It's a great pleasure to be working with Adrian. We've been working for about an hour now. It's very fun. We wish I could do this every week, but unfortunately, no. So we've got a great team here. Ure is going to help us. He's been helping us for about an hour now, and our circulating team and our radiographer. So we have a lot to show, so we're going to just quickly get straight into the case. 73-year-old lady. She is diabetic, and she had a bypass done quite a few years ago now, probably about 5 years ago now. So she had 3 grafts put in, lima to the LAD, and vein grafts to the PDA, as well as to a high diagonal. And then she started getting problems about 6 months ago. So started getting chest pain. She had a few investigations done. She was tried on medical therapy, but basically she continued to have chest pain, and finally in November, she came in for a cath. And during the cath, okay, we'll talk about the cath findings in a short while. So essentially, found a occluded vein graft to the right. The grafts to the left side were still okay. So the lima was all right. The vein graft to the diagonal was okay. So I actually did the diagnostic cath. It was meant to be a cath, and so did a bit of a half-hearted attempt at trying to recanalize the native RCA. So it was a left radial system, and managed to wire the RCA, but I couldn't pass any gear across the proximal RCA. That is the ECG there. So the R waves all preserved. The EF actually is normal on echo. So in terms of blood test results, everything's quite okay. Let's show the diagnostic cath, guys. Yeah. So this is the left side. So there's still flow down the native LAD. Some collaterals going to the right. Okay, next. Next, please. And this is the RCA. So you can see that it's still patent. Well, in November it was still patent and very calcified in the proximal to mid segment. Hope you can appreciate that. And next film. This is the lima is patent, and that is the vein graft to the diagonal. That's all patent. So the left side is quite fairly protected. Next. So this is the occluded vein graft to the right. Next, please. Yeah. So basically, I passed the soft wire down, couldn't pass any gear, and because I didn't want to persist with that, we stopped, and we brought her back today with the intention to open up the native RCA.
Okay, great case. So maybe before you go any further, maybe I'll have a chance to speak to our panelists and see what their view and what they're going to do about this case. It's going to be an interesting case. Maybe I will ask Nigel to start giving some comments from the angio.
Yeah, so patient previous bypass surgery, the target's a native vessel, so I think that's a good option. The patient's in an elective situation, but they've failed medical therapy, so I think we've got everything we need to attempt a difficult, effectively functional occlusion of the right coronary artery within a very calcified segment.
Maybe Dr. Junko, what do you think on the echo? They haven't done it yet, but look from the angiogram, looks very calcified.
Yes. The angiography shows a very, very complex morphology inside of the stenotic segment. And I believe that there are a gathering of calcified nodule, just like a coral, and lumens are very, very irregular. So that is one of the reasons why the previous the balloon was not crossed. So definitely we need some debulking like a rotabrator, and especially we have to start up with a very smaller burr, I think.
Kim-Chu, how you agree that?
I think all of us agree it's a very long, diffuse calcified disease, and you need some form of modification of the calcium. I guess this is a matter of choice whether you want to start with a rotational atherectomy or maybe the orbital is available. I would probably might think about orbital being, it's a very large vessel, giving a bit more debulking that I can achieve with the orbital device.
Yeah, maybe at this point, Adrian and Tang, what's your strategy here? Maybe start with, it looks like you have access, you know, and what guided, and what's your plan on this?
Yeah, so I think the consistent view is that this is a severely calcified, diffuse right coronary artery, and some form of ablative strategy should be considered. So we had decided on a transradial approach, and today we actually attempted a right distal radial access. So we actually made a short video clip of the process, detailing how we did it with ultrasound guidance. Perhaps we could just bring that online.
Yeah, nice.
Okay, so that's the patient's hand there, just to indicate the position of the anatomical snuff box there. And in this case, you could feel distal radial artery. Yeah, but I'm used to using an ultrasound approach, so that's what we did. So that's your transducer. So one of the things that you need to be clear when you're using it is to make sure that you have the transducer in the right direction. That's why you saw me swiping the side of it, just to make sure they're on the right side. And usually I would like the depth to be the lowest, so because it's a very superficial artery. And I'm not sure if you can see the vessel that is actually pulsating. And I like to give some local anesthesia under ultrasound guidance. So that gives me an idea of where the needle is going to go. And usually when you administer the lidocaine, the vessel might be a little more prominent. So I think we're going to skip a couple of frames. And there you can see the vessel there pulsating. So we're attempting access. In this case, it took us a couple of tries just to hit it, but we did manage to access the distal radial artery. So I think we can continue with the
Adrian?
Yes.
If I may interrupt a little bit.
Yes.
Switching from Malaysia.
Yes.
Tell me, why do you prefer to choose the snuff box approach to the radial as opposed to the conventional radial, if not the femoral? Because you may need a 1.75, no? It's a very big artery.
Yes, yeah. Okay, so we had decided beforehand that we wanted to use a radial approach. And my preference for a distal radial access is that I find that post-procedure hemostasis is much easier. Now with the traditional transradial approach and using a TR band, that's still a rather complicated protocol that you need to follow. And I've had a patient that actually had compartment syndrome because of inadequate monitoring. But with distal radial access, I found that post-procedure hemostasis is much simpler. You remove the sheath, you apply a pressure dressing with a Coban for 2 hours, and then you remove it, and usually you have actually very good results. So it's for hemostasis as well as patient comfort that we decided on a distal radial access here. Granted that femoral access is possible, but we felt that we were not going to use a burn more than 1.75. Yeah. You may also see that the patient has a vascular access in the right femoral, and that's actually a venous access. Now, because this is such a dominant right coronary artery, one of the concerns with an ablative strategy is heart block. So the consideration was to have venous access in case the patient requires transvenous pacing. But again, prior to our procedure, we had a discussion that there were some reports that instead of using a transvenous pacing, a simpler way would actually just be to infuse IV aminophylline. Yeah, what's the infusion rate again?
So we're giving about 250 milligrams over half an hour. That would be if we kept the infusion up. So you're getting about 4 to 5 milligrams a minute.
Yeah, so that was an alternative that we wanted to evaluate. So maybe we could just bring you up to speed on what the coronary angiogram today shows. Okay, so can you see on screen? So this was our first angiogram.
Yeah, so we have a 6 French system. This is a short tip AL 0.75 through the right radial artery. And, you know, this is what happens always when you go for a live course.
So there is a progression of the diffuse right disease towards a CTO. So our hearts kind of sank when we saw this, that it's going to be a long procedure, and we had better start working on it. Does the panel have anything to comment at this point?
Hi, Dr. Secco from Italy. Did you consider at this point to have a contralateral access? Because maybe since this one occluded, you may be able to see the distal part of the RCA.
Yeah, good point. Yeah, it's about 2 months since the last angiogram, so we thought that maybe it's not actually a very tight occlusion, and if you look at the angiogram, there seems to be some trickle of flow. So we actually attempted advancing a wire distally, and initially we tried advancing a rotor floppy, but it could not cross. You can see from this angiogram here that we stopped.
No, I agree that you can see some flow, but the problem is that when you will advance the wire, then you will completely lose the flow. This is the reason why maybe a contralateral access maybe would be helpful.
Absolutely right. Yeah, I think that was a good consideration, and certainly something that we should always keep in mind if we want to progress further.
Adrian, I think we're keen to see what you can hopefully bring us up to date, because we want to very quickly have a look at Jonathan Hill's case next door, because I think there's some progress being made on the other side. So maybe you can let us know what you have achieved so far. I think you have done quite a bit of work up front, right?
Yes. Yeah, so as you can see from the angiography, we had problems advancing a standard workhorse wire, a Sion blue. We escalated it to an XTA and even a Gaia second, but there was no progress. And we were actually quite considering whether we want to do also another bilateral access, but that would actually add considerably more to the time as well as the complexity. So we just thought that we're going to try a little more using gladius wire. And you can see from this angiogram that the gladius wire actually passed quite easily, and we were quite certain from the behavior of the wire that we were actually in the true lumen. But at this point, we couldn't advance the microcatheter beyond the mid-segment of the right. So we had to swap it out and attempted serial inflations with a small balloon first. This is a 1.0 by 5 millimeter Ray balloon. We got it to about there and managed to advance a little further, and we further escalated the balloon size to a 1.25 by 10. And eventually we managed to advance the balloon distally and swap out the gladius wire. This is a distal injection for a rotor floppy so that we could proceed with what we had originally intended to do from the beginning. So it was a long detour, and we started off with a 1.5 millimeter burr. We had a total of about 5 runs at about 190 RPM, and with infusion of the aminophylline. So there was no significant bradyarrhythmia, so it seemed like, at least for her, the IV aminophylline infusion worked, and it's a much simpler choice instead of putting in a pacing wire. So we'll just show you the picture. Yeah, so this is advancing a workhorse wire distally. Can we?
I think the only picture we have is our
okay. Yeah. Sure.
So we got an OCT catheter in, and you can see the angio when we did the OCT, and then we'll show you the OCT images. Yeah.
So maybe, Tang, we want to go over there for a short while, if you don't mind. Yeah, we have great experts here who can comment on this. So we will eagerly wait your outcome. But I try to go over to the other lab to see what the progress is like. So can we?
Sure.
Please, thank you so much.
Adrian, we are back with you. Tang.
Yep. Hi, guys.
So we came back. We just saw a beautiful illustration of IVL next door.
Okay.
But you are not allowed to use it in your room,
No.
I heard. So
we are the alternative camp. Alternative camp. All right. There's always two ways to do something.
Yeah, but you are the winning camp, right?
Okay. So maybe we'll show you the. If you remember the case, we did an OCT run. So could we show the OCT actually?
Yes, please.
Yeah.
Okay.
And we need lots of help interpreting this OCT.
Okay, we'll get Dr. Chin Chiang, who's OCT expert. So let us know how that shows.
Okay. Can we have the main window first?
Right, so this is, I guess, pulling back from the distal RCA. At this point, we start to see that the lumen gets quite tight. As very tight here. At this point, can't see a lot of calcium, probably because the overlying tissue is hindering it. Here we can see concentric calcium now, all around. This is after rotablation, right?
Yes, this is after rotablation.
Yep.
Yeah.
This is after 1.5 rotablation. Yeah.
Yeah. So yeah, heavily calcified segment there in the mid RCA. Here it's a bit more eccentric, and yeah. So as the angio showed, this is a very calcified lesion in the RCA. Probably need to prepare it a little bit more, obviously, before you start thinking about stenting.
I hope my wife is still there.
Thanks. So I'll show you all our secrets. Okay. Where was the pullback? Yep. So this is angiographically how it looks. Yep, you can see that?
Yes, on the small screen.
Yeah. So how should we progress from here?
So maybe I'll ask Dr. Kashima. Is one of the top rotablator experts from Japan. Does a lot of rotablators. So what shall we do after this 1.5 burr?
Yes, I always use it 1.75 for like these cases. Because then, of course, the 1.5 can work well sometimes. So 90% cases of like this situation, of course, and after 1.5 meter bar, any balloon can dilate it. However, about 10% cannot dilate it. After that, in chronic phase, and maybe will become the Jonathan's case. So it is not so good. So we always should ablate it and larger bar if possible.
Sure. Would you do a larger burr with 6 French or 7 French?
Yes, but in the 6 French accepted 1.75.
Yeah,
so yes, you can do it.
Yeah. So we decided actually to try a cutting balloon. And because today was the launch of Wolverine, we decided to try the Wolverine. We'll show you where it ended up.
Yeah, so on that note, actually, we did keep the rotor wire in because Adrian, we thought maybe we would still need to come back. But this is the Wolverine. It's a 3.0 by 10, right? Yeah, 3.0 by 10.
15, is it? 3.0 by 10.
Yeah, 3.0 by 10. Yeah. So it kind of, we hadn't obviously prepared things enough. So we couldn't deliver.
So we then next decided to use a regular non-compliant balloon. You can see that this is a Sapphire NC, a 3.0 by 15.
Yep.
So they actually went down fairly smoothly. But at this point here, you can see that there is a napkin ring. And this is at rated of 20 atmosphere. So we did try hitting that area a couple of times. I think that was the area that you saw quite clearly on OCT, a nice concentric calcium. Yeah, so you can see that there is a dot boning at the ends that just is not yielding to the balloon. So maybe the panelists would like to share with us what would be the next strategy.
Aaron, what do you think?
I think a lot of us at this end of the table would have gone with a 1.75 burr already. Maybe a little tight with the 6, but yeah, I think the OCT was really helpful. I mean, we had thick, concentric calcium over a long, long segment. So this was always going to be very challenging just with a 1.5 burr, I think.
If I may add, I was this concerned with a larger burr with a 6 French system. If you're using a distal radial, this radial is smaller. If you use a 7 French, sometimes you can't insert the whole sheath all the way through. But now with the Terumo glide sheath 7 French, so with a 6 French outer diameter, you can actually use the 7 French system.
Yes, yeah, good point.
Is orbital atherectomy would be a choice? Yeah, because of course, a 1.75 burr is another option. However, you use 6-inch bar and orbital atherectomy. You may be able to obtain a larger size.
Yes.
And after you ablate with 1.5 burr, so that the orbital atherectomy would be a choice.
Yeah.
But would that be a concern? My concern would be using orbital here is, you have a stent in place, and B, after the rotational atherectomy, you actually both dilate it quite aggressively, so there might be some dissection already in place. So you do the orbital, and the danger is actually sometimes it tears the vessel.
Maybe an easy way could be just to try an open and see balloon. I mean, usually they work, so maybe it's really fast and you can try it.
Come on, Tang, just
show
us what you did.
I want to see the shockwave.
Was that Dr. Seko's suggestion?
Open and see balloon at 40
okay,
atmosphere.
Here you go, OPN.
OPN.
Yep.
3015, and you can go up till 45 atmosphere.
Okay, so this is 3010. We have a 3010 OPN balloon.
Oh, sorry, okay.
Yeah, goes very nicely, inflating. We are very careful here. So that's it, inflating, and I think we went to 28. And the lesion gave. So we have that.
They work very, very well. I mean, they do work well.
Yeah. So that's where we are now. We have not taken any shots since then. We have no idea what's happening to the blood vessel now.
The hemodynamics are stable. That's reassuring. She's not complaining. Yeah, so
okay, so we're going to take a shot, I think. Is that all right with everyone?
Yes, we would love to see. Yeah.
Okay, all right.
So it looks better than before. I think we're going to have another go with the 3.5 Wolverine that we've opened to see whether it will cross this time.
Maybe the distal part need to dilate as well. There's another lesion distally.
Oh, you mean very distal?
No, just at the waist there, just maybe about.
Okay. Yeah. There is another lesion at the near the bifurcation. We've decided we're not going to go anywhere near that. Yeah. So.
You're leaving the rotor wire just in case you need to use it again?
We're using it also as buddy, because having another wire there while trying to get another device down helps. And if we're going to, but certainly we're going to be removing the rotor wire if we can actually successfully advance the Wolverine balloon.
Is it okay to deploy the Wolverine with a rotor wire in the vessel? Is that something anyone's done before?
Yeah, Dr. Kashima, what's your experience with the Wolverine? Can you use like 2-3 wires inside? Will you cut?
No problem.
Cut the wire?
No problem.
No problem.
Yes, we always use. We can always use the 2 wires.
How easily it went through now.
Thank you.
Because the Wolverine blade is not so hard compared with wire.
Okay. Okay. So shall we go up with the wire inside? Yeah.
Yep. Please go ahead.
Okay,
Show
let's
us.
do it. Yep. Okay.
Okay.
So
Yeah, it looks.
12
well
is rated.
expanded.
Yep. 12 is rated. Yep.
Take a seat.
Yep. So Kajima, can we go higher than 12? Is that allowed? I mean, not allowed, but would you recommend doing that, or?
Maybe we stick with 12. Okay.
No problem. I always use it more than 20 atmosphere,
More
but not official.
Okay. 18. The Lunar New Year is coming up. We need.
But if we use it more than 20 atmosphere, you pull out it another wire at first.
Okay. Okay. 18 down. Yep.
This is a tight part.
We probably have a slightly different experience when we're in 16 bar actually bursted. So I suppose it depends on the calcium, really, isn't it?
18.
18 is a good number for us.
Yep.
New year.
Down.
Sometimes more than 22 atmosphere cutting balloon can work well at this situation.
Okay.
Yes, so at first you put out the wire. After that, you try it more than 20 atmosphere.
Okay. 18. You want to do that?
Yeah.
Pull out the wire.
Yeah, I advance the balloon back in first.
Dr. Hone, is that your experience too? Yeah, that can go up to high 20 atmospheres. We are always worried.
Yes, my maximum is 20 atmosphere.
It's okay.
But it sometimes works.
Okay, I'm going to pull out the rotor now. I don't think we're going to be doing more rotablation.
And multiple times inflation of urbalin sometimes works. Yeah, and a longer inflation time. Not
Longer inflation
one
time?
short
Okay.
time, but 30 seconds for many, many times it works.
Okay, so the wire didn't get chopped up. It's still in one piece.
And the inflation, is it matter? Does it need to go slow like the scoring balloons, or fast inflation is okay?
Tang, I think, you know, we are interventionists. There is no slowly
There
going
is
up
no
balloon.
slow.
You understand?
Okay,
Yeah.
Okay, all right, so
2, 4, 6.
20.
I always remember what Colombo said. If you want to step somebody, it doesn't matter whether step slow or fast. Yeah, he doesn't care.
Same for cutting, right?
Okay. 20.
So I presume after this, you're going to do
20?
another OCT for
Yes.
us?
Yes.
Yeah.
Down.
So
you think this would have been a good case for a...
lithotripsy. Yeah, rotor lithotripsy.
20?
But this lithotripsy seems to be the kind of ongoing theme for this Congress. You know, the few sessions I went to, it seems to be a repeated topic. It just go to show the type of disease that we're dealing with these days and the degree of calcification and complexity. Really, this kind of tools is becoming very invaluable.
Yeah. But I guess this case so far, touch wood, has shown that we can make some progress without, you know, access to lithotripsy. So, down.
It's just a lot more tedious.
Yes.
I'm not sure it's cheaper, considering the amount of hardware that we've used.
Yep.
Okay, shall we go up to 20 again?
Okay.
Well, I've certainly learned not to trust a rated burst here. I'm impressed.
Yep.
At 20 atmosphere and it's still holding up.
Yep. Okay, down.
So the comment, Adrian and
Yes.
Chee and Andrew here, that there was still a significant amount of calcium on the
Yes.
on the inferior border, as you can see that
Yeah.
curve.
We're going to take a picture, then we'll make a decision.
Down.
Let me push the guy in. Take a picture now?
Okay.
Yep. Shall we do an OCT run? You want to do from distal part?
Yeah.
Since they have
maybe
constants,
about
yeah.
here.
Yeah, sounds good. Hang on, it's bulky. Again, it's stuck.
I open the way. I open the...
Yeah.
A bit of wire balloon fusion.
Yeah. The OPN actually had a fair amount of this, yeah.
Less with the Wolverine.
Yep.
Is this a Sean wire or what kind of wire is it?
Cyan blue.
Yeah, you know, this seems to be the recurrent one, isn't it?
Yeah. Got it?
Yeah. Got it. Oh, it's tight.
I know we are supposed to close around this time, but the case is very interesting, so we will try to follow and then close a bit later. Like to seek the indulgence of the panel as well as the audience.
So in other words, Chee Tang, Prof Ko is hurrying you up.
Yeah, we got a hint.
It's okay, we'll finish up this case while we wait for you, Aaron, to come and do all the other ad hoc cases.
Okay, so I think that's a demo of why the OCT catheter needs improvement. So this is only the second run, and you can see that we have issues. We may need a new OCT catheter. I don't think we'll see that with IVUS, but that's the problem with the OCT. No, we're going to use a new one.
What's cheaper, a new OCT or a guideliner? I think in a perfect world going forward, certainly in our geography, the same here locally in Singapore, we can't use shockwave. It's not approved, it's not reimbursed, but these very big right coronary arteries, really heavily calcified, as Dr. Kashima said, it's not uncommon following good debulking with rotational atherectomy, maybe 10% or more, we can't dilate a balloon, where I think shockwave would be an adjunct, concentric calcification to rota. Perfect world.
Yep.
Yeah, so my question is, if you look at this here, the proximal and mid RCA is still under expanded. Would using shockwave here just improve your diameter opening up to the 3.5 that it should be? I mean, it's constrained by the old stents, but certainly with shockwave.
There's no stents.
It's all calcium.
It's all calcium. Yeah. So would shockwave just melt it a bit more?
Yeah, but unfortunately we don't have access to it. We would have loved to.
That's just echoing Nigel's perfect world scenario.
Yeah, certainly with the imaging, if we see a lot of concentric calcification through that segment, I think that would be the way forward.
But in practical day-to-day terms, if I'm seeing this lesion, I probably will just continue to implant the stents and see how it does.
I think so. I think that's reasonable, Tenha, is that we got OCT, you see the diameter and just get a stent down there, no?
No, because sometimes they see it's not fully expanded then. But that's with OCT, you can see much clearer with the calcium. But if you don't have that, then looks reasonable. So
we'll probably have to do 2 runs. Yeah, we're going to do from the distal, then back to the mid. Oh, come on.
It's probably the calcium shelf that you disrupted, isn't it?
Yeah. You probably made a small little spicule or something stick out.
So I'm just wondering, Adrian, whether you would consider changing this wire out maybe to something like a wiggle wire.
That's a good point.
Just deflect it. And I think subsequently, not just the OCT catheters, you also stents and all those probably will still face the same problem.
Maybe just lift the guide up a little bit, change the direction, maybe you can go down straight.
Nope. It's going to anteriorly.
Or deep breath.
Can we stand by a wiggle wire?
Hello, Auntie 啊，来深呼吸间，深呼吸。
OK， 没有，继续睡觉。
OK， 好的，
很好。
啊 ，OK。Thank you for the suggestion.
Yeah, Dr. Hong Ye, that was excellent.
Welcome.
Yeah. Oh,
hard work, huh?
I hope the Abbott engineers are watching this.
If you want to look slim and slender, you have to work hard at it.
I think it's as far as I can go. We're going to do a run from here.
Yeah, okay.
Can we see the OCT on the big screen if possible?
Shall we get? It's the flow rate we need to set. 420, yep.
Let me just check, can you?
Sure.
Retransfer?
Yeah. Yeah.
Okay. Yeah. Okay.
Let's go. Pull back. Yeah, I can go in a bit more, if possible. I'll try.
So Chee, any comments?
Yes, I've gone in a bit more.
Yep. So yeah, so we can see there the lumen is definitely bigger. There are dissections now, which is what you want to see, I guess, when you're preparing such a calcific lesion. Okay, again, pulling back from the distal. It's quite a big vessel.
Yeah. We measured the EL earlier to be more than 4 millimeters.
Yeah.
Yeah. Yeah, you can see the calcium's nicely disrupted. Dissections everywhere, which is contained, so that's good.
Big
Yeah,
crack there.
big cracks in the calcium, which is what you want to see again. Yeah, I think it's probably looking good to proceed to stenting.
Yeah. Do you want to put it 4-0? Yeah. Yep.
Okay, come 4-0, long one.
Just to note that there are dissections that extend to your guide catheter, so
Yep,
you,
yeah.
you probably have to disengage to.
Yeah, we're going to be standing all the way back to the ostium. We're going to try and put a distal stent first. We're going to use a 4 millimeter stent based on the OCT measurements.
32.
Yeah, we're going to try with a 38 first to see if we cross.
You don't have the co-registration function with the OCT?
This machine apparently, the co-reg doesn't work so well. Yeah, so it doesn't have it. Yeah, the other machine I think was in the other lab. Yeah.
Are you planning to do 2 stents or 1 stent does it all?
It's going to need 2 stents. Yeah.
So would it make sense? I'm just thinking out loud whether it's worth at this stage put a buddy wire down, deliver a slightly shorter stent, just gel it, and then you put your big stent more proximally. It would. Are you gonna?
Let's see how it goes. Let's see how the stent performs here. I never like jailing wires in calcified lesions.
Yeah. It's the last session of the day, so we're gonna push all the equipment to the max. So we're gonna try a 4-0-38.
So what stent have you chosen at the end?
This is.
I will tell you when it crosses, right?
Okay. Yeah. You can guess then.
Put the angel. Yeah.
We might need a guide extension catheter. Yeah.
Telescope.
Yeah, the telescope.
Yeah. Telescope. Okay, I think we were a bit ambitious.
Maybe take a deep breath in again. Yeah.
It's possible. You talking about me or the patient?
Both of you. Both of you.
Okay. We stopped breathing about half an hour ago already. Auntie, 来，深呼吸，深呼吸，深呼吸，停止呼吸一下。
Okay, I think it's no go. Let's try the telescope.
All right. So we'll get a guide extension down.
Do you want a balloon to lead in?
Okay.
Yeah.
So just now we
have a 3O balloon, right?
Yeah. We still
Let's
have
use that.
NC, the trio NC.
There's a fire, is it?
Yeah.
Okay, we can do that. So we'll save the stand.
Can I just make a comment? I come in late, so I didn't follow the case. But what we sometimes use is we combine a soft wire and a rigid wire. And then you put the balloon, the stent basically on the soft wire. The rigid wire will hit the stent. I don't know over the plaque, and the soft wire will enable you to get the stent down. I'm not sure it will work. And the reason why inspiration helps is it pulls on the wire. It pulls the wire away from the wall and enables the probe to pass.
Yeah. We suggested to him, but he wants to try the guide later.
Yeah, we have a new guide extension. This is the electronic, right?
Yeah.
Yeah.
So we're trying this telescope guide extension.
So we're reusing the 3O non-compliant balloon to lead in.
So is there any advantage for this extension?
Yeah, it's supposed to have a more gradual transition point. So the balloon actually went in very smoothly. There was no need for us to make any adjustments. So this went in very nicely. We're going to just go up with the non-compliant balloon. Yeah, 12. So I'm going to just advance the guide extension now. So easy peasy. Yep, okay, good. All right. Balloons down. Yep, we're going to just...
you want to get further down?
Okay, let's see. Let's see.
Yeah.
Let's
nice.
go a little further. Up.
6. Guide is a bit up.
Yeah. Okay.
Okay, down.
Okay, so our guide extension catheter is all the way down. The stent should cross. Will cross. Let me just. Okay, second run with the 4.0 by 38 millimeter stent.
This is a fascinating case, Adrian and Tang. I'm actually in some way quietly being quite glad that you guys are the one doing it. But IVL have made it too easy. You know, this is the last case, the anchoring case for the Congress. So we want to see you guys sweat, and I want to see, you know, really a good case and good operators, you know, demonstrating all these new techniques and new devices being used. It's brilliant.
Okay, I feel a little resistance. Can we just fluoro and see?
Yeah. Off mic. Yeah. Yep. Open up. Yeah. Just make sure the transition point is. Yeah. So I think Adrian alluded to this before. The problem with guide extension is sometimes you don't want to knock onto the. So you can see that marker. I think that marker is where the.
It's not going in.
Where the I don't know what do you call it? The transition point is. Yeah. So it's a bit far away still. Huh?
Sometimes the wire wrap around the rebound.
Yeah, good point. Yeah. So you think we should?
Yeah, it's better if we can get it.
Let's see. Yeah. I think it might be the wire wrap. Huh? Maybe let's take out the stent and then we try and.
And it's a 4.0 stent.
It is a 4.0 stent. Yeah.
Can we have the 3.0 balloon again? Let's see whether it goes in smoothly.
But just now you went in quite well because you dilate it and push it in. Maybe it's a stent because it's a bit more bulky, so we may have to just take out the telescope again. Just reinsert it again. Yeah.
Okay, we're just inserting the balloon to see whether it has the same issue. So this is the earlier balloon.
Any other suggestions?
So the balloon is also stuck. I think it's a wire wrap around. Okay, so let's see whether we can.
So let's check how much how much we can pull back that thing if we need to. Right?
Have you guys checked the ACT? It's been quite long.
Yes, we checked earlier. It was 288. We topped up another 2,000 just prior to coming live. Thanks for the reminder.
Come, sit down. Yeah. Sit down.
Because it's been very long already.
Yeah. Okay, so that's our guide extension. The wire.
Extension guide can already cover the region, so you pull out the wire. After that, you make a rewiring, maybe, and the twist is release.
So you're
pull the wire back.
Yes, right.
Okay. Yeah. Yeah.
Because no problem.
But sometimes when you rewire it, it go underneath the
yes, of course.
the guideline. So, yeah.
No problem.
Maybe
easy solution.
You think the safer bet would be just exchange out the wire? Yeah, microcatheter. We have the Kusabi.
Yeah. How about we put another? We've got a microcatheter.
Yeah.
Do you think that would be safer? We put a microcatheter down
it's faster. Just pull out the telescope and push in again. I think it's just.
Okay. You think we have smoothened out the road?
All right.
The other way actually is that we can load the stent with the telescope.
Yeah. Why don't we do that? We load the stent with the.
Another choice, of course, is to waste some more money and use a smaller stent, shorter stent. That might also help.
That's true. Well, we've really used up a lot here. Shall we try?
Together with the
with the stand. So we're going to try and load the stand in, and then we're going to advance both up, just to make sure that. Okay, so do you want to just take a scene just to prove that this can go inside?
Okay. Can you? Are you seeing?
Yeah.
Now, can the camera go a bit closer to their hands? And I presume you check the stand is still all intact, right?
Yeah. It's all in there. It goes in really smooth. Yeah. There's no issue.
Brilliant. Thanks.
Let me try and advance it together.
Hang on. Let me hold on to the wire first.
Sure.
Okay.
Okay, I'm advancing the guide extension together with the stand now. Holding on to both wire.
But the thing is, you might need an anchoring balloon to push down the telescope again. Yeah.
Let's see how this goes.
I think it would be it's hardly compatible. A guide liner in a 6 French and the balloon inside. If you need 2 wires and then you do an anchoring balloon, this is not going to be compatible with a guide liner.
Yeah, so I'm not sure whether the guide liner can go in.
Okay, we have the stand here.
You want to get the.
Okay, let's see whether the guide liner.
So this part is a little bit.
It's telescope. It's not guide liner.
Yeah. It looks very smooth. Yeah. The problem always here is that sometimes you can scrape the stent as you.
But it's going quite smoothly.
But this looks very nice and smooth. Yep.
Can we start that?
All right.
I'm going to advance this a little further. I think we're far enough.
Yeah.
Yeah. I'm going to just pull this back a little.
Let me put a reference. Where do we want to put it?
I think we're beyond. Yeah.
Okay.
We have to be proximal enough so that we don't have to go past that pen again, right?
Yeah. I think this is okay, right? Yeah. Around here.
Guide extension. Back.
Small test.
Yeah. In fact, we can pull back a bit more.
Yeah.
So the stand. Yeah?
Yep.
Shall we go here?
Yep.
Okay.
Yep. See.
All right.
Nowadays, with these modern stands, they are very all low profile and very thin struts. In this kind of very severely calcified lesions,
and
is there a need to use more sort of thicker strut stands?
Where 12?
What do you think, Dr. Nigel?
Yeah, later we can.
Yeah, look, it all comes back to the old-fashioned thing of radial strength, doesn't it? You know, a new stents are a trade-off. You know, 2-connector, flexible, deliverable, low profile, but you know the trade-off compared to the old stainless steel.
Careful with the distal wire, Adrian.
We lose that radial strength.
It's in that small little.
Pulling back. Thanks.
But there's coming up. There's a stronger stand from Boston, right? The Megatron. Again, going down that route of stronger stand, thicker struts.
But will that be a long stand? It's supposed to be quite short, right? That's supposed. Do you think it would be useful for large RCAs like this one?
8, 10, 12.
They're probably encouraging to use more than one.
Yeah.
Maybe approximately we go higher pressure.
Yeah. So we are at 18 actually. Yeah.
Okay.
Okay, down. Yep.
Can trap the telescope down now, for the next stand.
Yep, good idea. I'm going to just advance the telescope. Down. Down.
Yep, down.
this is a bulky balloon. Wow. How long a stent do you want to use? Yeah, we had a...
Maybe we can pause it as the thing flies out.
That's a good idea.
Any suggestions for the next stent?
I think another 38 maybe. You have to cover right to the ostium, I think.
Yep, yeah.
What we normally would do is whichever balloon you have in there, just put the balloon in and measure the length.
Yeah,
That's what we normally would do.
I know, we were so excited to take things out. But we have so you can see we have this thing on the way out. Although I'm not sure that's the ostium.
Yeah, I think 38 is a good choice.
Yeah, certainly with the co-reg OCT system from the outset, you can, very accurately determine your treatment segment and plan your stent, your stent length, back to guide, obviously here back to ostium.
So we're going to go with another 4038.
So we'll try to see your stent deployment, and then once it's deployed, we'll probably have to close because that probably will be done.
Okay. Thank you very much for staying with us through this whole thing. I have to say it's been really very, very enjoyable working with Adrian.
Yes, same here.
We should do this more often. Okay, all right. So does it go into the... okay, so this time it goes into the telescope, no issues.
I think it was a wire wrap earlier because it's going in very smoothly now. Oh, it's like butter.
Okay.
Okay, even the telescope is back. I'm going to just pull back now and see where the ostium is. That's about the ostium. Back another dot.
I think a little bit more.
Yeah. Yeah, it looks. There we go. Yep, show you that picture here.
Okay. We may have to come back one. And then maybe okay.
Come back one more dot. I think safer.
Come back a little bit, you think?
Yeah, looks like just a few dots.
Okay. Okay.
You push it in a bit. Yeah. Yes.
Okay.
Yeah. Take picture.
Yeah.
I think this looks reasonable. Okay.
Yep.
Let's go.
Yep.
So for transradial, you have to be very careful. You have to fluoro it because when the patient take a deep breath in, everything moves.
Yeah,
so you may
we're doing
change
a fluoro.
position.
Yeah, that's a good point, Aaron. Thanks for reminding us. Yep. We're at 12. Yep.
And the stent balloon seems to open up really nicely, Adrian.
Yeah. Down. Okay, we're going to try and see whether we can advance the stent balloon in a little bit. Shall we? 12.
12, huh?
Yep.
Okay, now.
And we're going to pulse dilate now with the 4O.
You want to flare the ostium a bit?
Yeah, I'm going to pull the balloon back.
Shall we take a shot? Shall we do an OCT or take a shot? And then we can pulse dilate after.
Okay, sure.
This, I think, going off.
Yeah.
We want to pulse dilate, but maybe we'll do an OCT to show you guys what we have at the moment. Is that better? And then we can polish it up later. What do you think?
Well, I think the thing looks excellent already. But I'm sure you can do OCT at your own time. And
okay.
So we would like to have an angiogram to see
sure.
really, and then really,
Okay.
Yeah, close the session.
We put the OCT guide in for the angiogram, save the contrast.
Okay. Can you indulge us in a few minutes? We put in the OCT and then we take the shot. Is that okay? Because then we save contrast. No? Okay, we'll take a shot now. We'll take a shot
Take
now.
a shot, yeah.
Okay.
Yeah.
All right, let's go.
Okay.
I'm sure it looks nice. Yeah, it looks like, yeah.
Otherwise, we won't clap for you, Chee.
I know.
Okay, it's been a really nice demonstration. It's a tough case. Sorry, we gave you one that closed off in the meantime while the waiting for the case to be done. So, any last words from Adrian?
No, I had a great time working with your team, with Chee Tang. Yeah, I really would be happy to work with him again.
Yeah.
You can come over if you want, Adrian.
I can go over, so it's okay.
Yes,
I
don't
don't
mind.
Welcome.
So you are really the slender club guys, huh? Although both of you are very slender and 6 French, yeah. Okay. So I think with that really a nice demonstration, let's give them a big round of applause to end the show at the Sing Live this year.